Okay, thank you very much, Stefan, for this kind introduction, and thank you for the invitation and the opportunity to share some thoughts about salvage surgery for esophageal cancer. And the question that has been raised was whether this salvage surgery is routine or exception. So we'll go on see a little bit of context of salvage surgery and what is the definition of salvage surgery. We'll then see what is the justification of salvage surgery, and then we will analyze in detail the postoperative outcomes of salvage surgery and the oncological outcomes that can be expected from this particular type of surgery. Now, going to the context, you all know that the three-modality treatment makes better than surgery alone in adenocarcinoma and in squamous cell carcinoma. But however, is this surgery necessary for all the patients? It has been shown in several publications that when you have a patient who is responder to induction chemotherapy or induction chemoradiation, you have in fact a similar prognosis when you operate the patient or when you don't operate the patient. So maybe this is because some patients do have a very good response to primary chemoradiation, and some patients have a pathological complete response. We already discussed this morning with 1/3 of the patients who have no residual tumor on the primary tumor site and in resected regional lymph nodes. We already discussed that the rate of pathological complete response was higher in SCC than in ADC. So maybe for those patients, there might be a place for an organ-sparing approach. What could be the potential advantage of organ-sparing approach? Well, you avoid a significant risk of postoperative morbidity and mortality to those patients who should have undergo surgery. There is also a potential negative impact on health-related quality of life of surgery, regardless of the approach, meaning even if you propose a patient a minimally invasive surgery, you have an impact of health-related quality of life. You may avoid surgery for patients who have pathological complete response, but also for patients who have micrometastatic disease, meaning that in those patients, when you do an operation and 2 or 3 months after they develop metastases, probably they already had metastatic disease at the time of surgery that was not present on the morphological examination. And maybe when you do surgery in those patients, you induce an immunosuppression that favors the development of those metastases. So in fact, to answer this question whether surgery is necessary after primary chemoradiation, you have 2 randomized phase 3 trials, which were already published, which are a little bit different. The first trial is a German trial, which included only squamous cell carcinoma of the upper third and middle third esophagus, and was published in 2005. And the second trial was a French trial, and that compared exclusive chemoradiation to exclusive chemoradiation followed by a surgery. And interestingly, in this trial, only patients who were responder to primary chemoradiation were randomized between pursuit of chemoradiation and surgery. You all know the results of those 2 trials that both demonstrated the non-inferiority of the exclusive chemoradiation arm when compared to patients who underwent chemoradiation followed by surgery. But it's not the end of the surgery, of course, because there are potential pitfalls in this organ-sparing approach. And the first pitfall is that how to evaluate response. This was already addressed this morning, and how to address response and to evaluate response and to predict pathological response. And the other pitfall of this approach is that in both trials, the local regional control was significantly worse in patients who underwent exclusive chemoradiation. So in fact, the concept of salvage surgery comes from this point. And instead of wait and see, we prefer the term of active surveillance. So in patients who have apparent complete response after primary chemoradiation, you go to active surveillance. And if there is an isolated locoregional recurrence, you propose them salvage surgery. So regarding the definition of salvage surgery, it's a surgery that is performed after exclusive chemoradiation. The delay is variable in the literature, but there are two, in fact, cases: patients who undergo salvage surgery because of tumor persistence after primary chemoradiation, and patients who undergo salvage surgery for distant recurrence, isolated locoregional recurrence. So this salvage surgery is in fact relatively recent because it appeared when exclusive chemoradiation strategy appeared. So when you look at this review of the literature that was published 10 years ago, there was in fact very few cases that were published, and when you look at the number of patients and who underwent this salvage surgery, it was 1 to 3 patients a year in each team that published this, that was published. So what is the justification of the salvage surgery? Well, for the justification of a patient who to go for salvage surgery in patients who have persistent tumor after primary chemoradiation, you have to go back to the results of the French trial. Remember, in the French trial, only patients who had a response to primary chemoradiation were randomized. So patients who had a bad response to chemoradiation were not randomized, and you could do whatever you wanted with those patients. When you look at the survival curve of those patients who were not randomized, you can see that the survival curve was not so good when compared to patients who were randomized. But in those patients who were not randomized, some were operated on and some were not. And when you look at the survival curve of patients who underwent operation and who are not randomized, you can see that the survival curve of those patients is similar to the survival curve of patients who were randomized, suggesting that this salvage surgery in case of failure of chemoradiation allows to give you a better survival and similar survival to the survival of patients who were randomized in the trial. Now, going now to the problem of the patient who have an apparent complete response and who have a distant locoregional isolated recurrence. You have no trial that has been performed, but this study that was published in 2012 is very interesting because it concerns a very limited number of patients who had squamous cell carcinoma with exclusive chemoradiation, and some patients underwent salvage surgery, and some patients underwent palliative treatment, and some patients underwent chemo or radiation. And even if the number is very low, you can see that it's highly statistically significant, and the benefit of salvage surgery is really obvious in this publication. Now, going now to the results in detail of this salvage surgery in terms of complication of oncological outcomes, when you look at the review that was published 10 years ago, and you see the postoperative outcome of those patients who underwent salvage surgery, you can see that the postoperative outcome was not so good, with the hospital stay going up to 47 days, anastomotic leakage going up to 38%, conduit necrosis in 25% of patients, pneumonia risk nearly 40 patients, and in-hospital death in this French series from Bretagne was 33, which is probably, I think you will agree with me, unacceptable, even if the oncological outcome of those patients who survived to this salvage surgery was not so bad, with 5-year survival rates around 25 to 35%, and prognostic factors that were identified were R0 resection and a long delay, between chemoradiation and surgery. Now, just 1 year after, there was this interesting publication by a French team from Marseille, which analyzed the results of the Salvage surgery in their series. They had a pretty high risk of 90-day mortality, 21%, and a high risk of postoperative morbidity with good oncological outcome. And what they studied was the result of the patient according to the dose of radiation that was performed during the chemoradiation. And interestingly, they found that with a cutoff at 55 gray, you had nearly a double risk of postoperative mortality and a double risk of postoperative morbidity when you operated on patients who had more than 55 gray during the chemoradiation. So in 2013, Marker and collaborators published this literature overview of 8 studies comparing the postoperative outcomes of salvage surgery compared to patients undergoing surgery after neoadjuvant chemoradiation. And they also found that the postoperative mortality risk, the risk of complication, surgical complication and medical complication was higher in patients undergoing salvage surgery. But in these reviews, there was a limit, and the limit that there was no analysis according to the period. There was no analysis regarding the delay between the end of the chemoradiation and the surgery, no analysis regarding the number of gray that were given to patients, no analysis regarding the volume of the center, and finally, we didn't know whether those patients were comparable between the two groups. So in 2015, we did a large retrospective study in France in all centers where oesophagectomy was performed, and we selected among those 3,000 patients undergoing salvage surgery, and we compared them to patients undergoing neoadjuvant chemoradiation followed by systematic surgery. And interestingly, among the patients who underwent salvage surgery, we analyzed separately patients who underwent surgery for persistent tumor and patients who underwent surgery for distant recurrence. We performed some statistical analysis and used a propensity score match in order to render a patient comparable. So the first message of this study, when comparing all salvage procedure to a patient undergoing surgery after neoadjuvant chemoradiation, was that in-hospital mortality and in-hospital morbidity rates were not statistically significantly different between the two groups, with mortality rate around 8 to 9%. In-hospital morbidity rate was high because it included all kinds of postoperative complications. However, and interestingly, the risk of anastomotic leakage and surgical site infection was higher in patients underwent salvage when compared to patients undergoing surgery after neoadjuvant chemoradiation. So regarding survival, no significant difference between those two groups were found. Interestingly, and following the results of the Marseille team, we performed a subgroup analysis, and we analyzed those postoperative outcomes according to the volume of the center and according to the dose of radiation. And we found also a very good, very high difference according volume center and dose of radiation in terms of postoperative mortality and postoperative morbidity. So in the second part of the study, we compared patients undergoing salvage surgery for persistent tumor versus patients undergoing salvage surgery for recurrence. And we didn't find any significant difference regarding the postoperative outcomes between those two kinds of salvage surgery. Regarding the survival of those two groups, The difference was not statistically significant, sorry, but probably due to the small number, but you see that patient undergoing surgery for distant recurrence had non-significant better prognosis than patient undergoing surgery for persistent tumor, but it reflects the fact that those patients had initially a very good response to chemoradiation. So after this study, we concluded that salvage surgery in the modern era can offer acceptable short and long-term outcomes in selected patients, but this should only be performed after a reasonable dose of radiation, lower than 55 Gray, and this also should be performed in experienced centers. Now, we went further in the analysis in this population of patients undergoing salvage surgery in this series, and we found that in multivariate analysis, the radiation dose higher than 50 Gray was a significant predictor of severe postoperative morbidity, and was also a bad prognostic factor regarding the 5-year overall survival. Now, if we go now in the literature, comparing patients fit for surgery who either undergo surveillance with salvage surgery in case of recurrence, and compare them to patients undergoing systematic surgery, you find 4 retrospective studies, and I put the results of one of those 4 studies, which is a well-designed study with a propensity score analysis, and comparing patients undergoing 3-modality treatment versus a patient undergoing 3-modality and active surveillance with salvage surgery in patients who were eligible but who didn't want to go to systematic surgery. And as you see on this slide, the baseline characteristic of those patients were well balanced, and the long-term outcomes of those patients were similar, with 31% of the patients who were in the active surveillance who finally underwent salvage surgery. So this is important because this means that salvage surgery has been offered to 31%, and when you go further and you see the other publication, the rate is usually between 25% to 35% of patients who are in active surveillance who finally do have to go for surgery because of isolated locoregional recurrence. So now, where do we stand? We have 2 randomized trials that are currently in course in Europe for testing the hypothesis that active surveillance may be an option for a patient after primary chemoradiation and clinical apparent complete response. So the French trial, which includes adenocarcinoma and squamous cell carcinoma, when we randomize in patients with clinical complete response between observation and surgery in case of recurrence versus systematic surgery. And the other trial is a Dutch SANO trial, which is going to begin, and which is which follows the pre-SANO trial that was mentioned this morning, which is a little bit different because there are 2 morphological evaluation, one after 6 weeks, one after 12 weeks. And after 12 weeks, if there is still a clinical complete response, the patients are randomized between systematic surgery and active surveillance with salvage surgery in case of local regional recurrence. So regarding salvage surgery, in fact, you have 2 types of surgery. What we really call salvage surgery is that when you have a patient who is in a situation of not complete response after a primary chemoradiation. And the second one is the salvage, well, not really salvage, but it's the on-demand surgery. When you have a patient who has a clinical complete response, you make an active surveillance, and the patient has an isolated locoregional recurrence. Those patients should be operated on in expert centers with lower than 55 gray of radiation, which is recommended. And regarding the question that was asked to me, salvage surgery has been an exception. It is now an option, and we already saw this slide, which are the ESMO guidelines of 2016, showing that in squamous cell carcinoma, you have either the option of neoadjuvant chemoradiation followed by resection, or the option of definitive chemoradiation followed by salvage resection. I fully agree with what Florian Lordic said this morning, meaning that you have to decide this at the beginning of the treatment outside a clinical trial. And maybe this salvage surgery maybe will become routine according to the results of those two trials that are actually including patch patients. I just wanted to have a special thought to Christophe, who left us last year. I wanted to thank him for all what he did in the field of esophageal oncology and esophageal surgery. I wanted also to thank him for giving me the opportunity to work him during those last 13 years. And that's all. Thank you very much.